Reigniting colorectal cancer screening as communities face and respond to the COVID-19 pandemic. I'm Caleb Lavelle with the National Colorectal Cancer Roundtable. And just quickly, the purpose of today's webinar is to provide an overview of the National Colorectal Cancer Roundtable's new playbook on colorectal cancer screening during the COVID-19 pandemic. We're going to discuss the immediate and long-term implications from the pandemic. And then we're going to begin unpacking how to activate around the playbook and find areas of opportunity. Like I said, we have lots of information, lots of slides to get through, but we do want to make sure that there's an ample amount of time at the end of this call for some Q&A. We have a fantastic lineup of speakers and NCCRT members presenting today. All of these folks were also lead authors on this report, and we thank them for all the time they contributed to put this together. So we have Rachel Issaka, Stephen Itzkowitz, Michael Sapienza, and a quick note about Michael and the Colorectal Cancer Alliance have been great partners throughout this process, coordinating the work and keeping the conversation going and keeping this work going, and offering a lot of in-kind staff time through the Colorectal Cancer Alliance too for these projects. Massam Suk and Richard Winder are lead editor on the project. And then we also, Dorado should give special mention to Dorado Brooks, who was another lead author, but is unable to attend as a presenter today. Just a couple of virtual housekeeping tips. The event is being recorded, and the replay and the slides will be made available on the nccrt.org within a few days. All participants are going to be muted, so please do submit your questions through the Q&A box at any time. We're going to be monitoring the question and answer box. You can use the chat for any general comments or any technical questions, but it will be the Q&A box that I'll be monitoring primarily for question and answers at the end. And then do please complete our evaluation, which we will send out at the completion of the call. And again, slides, I promise, will be sent out in a follow-up email. So now I'll pass over to Dr. Rich Winder.
Hi, everybody, and thanks, Caleb. And Caleb's done a terrific job being our team captain. A lot to cover. We're going to move briskly, but we want to make sure that we have plenty of time for discussion. So let's get started talking about level setting. Next, Caleb. So, you know, it does feel like a lifetime since COVID-19 changed our world. But we were off to such an incredible start in the colorectal cancer screening world. We had our March 5th, 2020, 5th annual March Colorectal Cancer Awareness Month broadcast. We celebrated our National Achievement Award winners. We had data from the 2018 campaign, kind of our final report, which we got to share. There were enormous array of events that happened all around the country, and it was absolutely shaping up to be one of our most momentous and united colorectal cancer awareness months ever. And then, as all of you know, the world changed. Just to recap some key dates, on March 13th, the US declared a national emergency. On the 14th, the Surgeon General advised that hospitals postpone elective surgeries. On the 15th, the GI Society said strongly consider rescheduling elective non-urgent endoscopic procedures. Around the exact same time, the ACS, for the first time in its history, great champions of screening, said no one should go to a healthcare facility for routine cancer screening until further notification. But the focus, which I think was difficult and remains somewhat difficult, is that these messages related to people at average risk, and it was not intended to relate to people with signs or symptoms who may have more urgent needs, but it's awfully hard to give a perfectly tailored set of messages in the middle of a crisis that we were just even remotely beginning to understand next. So what are the implications of this? We've seen an unprecedented drop in screening for breast, colorectal, and cervical cancer, decreases of 83 to 90% compared to the prior averaging of the previous 3 years. And you see the enormous, almost complete drop in number of colonoscopies. And this backlog is going to create an enormous challenge for all of us as we try to get back up to screening next. So here's what happened. I mean, if you talk about falling off a cliff, this is not measured in months or years, it's measured in weeks. You saw a virtually complete drop off of colonoscopy rate per 100,000, just very few remaining, and presumably only emergency ones, one would think. Next. And this led to what you might imagine, a very abrupt decline in the number of cancer diagnoses. So I think the message here is that there were clearly people with symptoms who stopped coming in for care. And there were people who, just through screening, where we occasionally find cancers in a routine average risk screen, who we know are at risk now for adverse outcomes because of delayed diagnosis. Next. So there's been a variety of estimates of delayed or missed cancer diagnoses, and IQVIA did one of these sets of estimates. And if you look, I think all of these data are really important, but I'll just draw your attention to the colorectal line, which looks at how they did the model, and then concludes that about 18,800 delayed colorectal cancer diagnoses as a result of the abrupt reduction in screening. Next. The real ultimate question is, what will be the burden in terms of suffering that we otherwise might have prevented? And I think all of you know that the main outcome that we want to prevent is death. And you'll see that in the modeling, it's estimated that a very substantial over 4,000 colorectal cancer deaths would occur, over 5,000, yes, over 4,000 in the following decade as a result of this period of delay. And remember, we don't know how long it's going to take to get back up to speed. So this number is going to actually be larger than what I'm showing you here, because we are not going to just reach a date, click our fingers, and get everybody back up to speed. These delays are likely to continue for quite some time, particularly without urgent action. There are also people who are going to require more therapy as a result of delayed diagnosis, even if they are able to be cured. Next. So what are some of the long-term barriers and challenges to screening? And that's really what we kind of tackled in this roadmap. The first is that there's going to be an exacerbation of screening inequities. I really thought, more than anything I can remember in my lifetime, COVID-19 shed a new and very bright light on the nature of inequities. I think people become inured to saying, well, blacks have higher mortality than whites, the Hispanics, Native Americans, Alaska Natives. This gave a face to what it means and why inequities occur. It's the nature of jobs that people have. It's the risks that they encourage, how many people are living at home. It's the number of burdens they face. It really absolutely revealed the complexity of factors that lead to inequities. And just as we saw more disparities in COVID response, the screening inequities will also be exacerbated, and they already were high. The second huge concern is this staggering loss of employment and health insurance nationwide, employer-based. The latest number I saw is that there are already 5.5 million more uninsured. The number one barrier to screening is lack of health insurance. And we don't know really what that number will ultimately be, nor do we truly know how others are being insured. Some of them might have some insurance that requires a big out-of-pocket expense, and they're going to delay screening. Third, and this was something that really came through, and I've experienced it myself during my telemedicine sessions, although I'm learning, is these complexities of moving to telemedicine, as well as other changes to the health system process. One of our first webinars, we had a family physician on who said, listen, I'm doing telemedicine. They're not all the visits about COVID. And the exact patients that, had they been in front of me, I would have recommended screening in using an opportunistic model. I'm just not thinking about it right now. I just not in the habit of doing it. So it's great to say that telemedicine is going to become a incorporated part of our healthcare system. But if that's to be true, we really have an urgent need to make sure that opportunistic models and planned models of screening are included in telemedicine, including how to make sure that whatever test you ordered gets executed. The fourth issue that is so critical is that we may be ready to go. We may be completely confident that screening of a variety of types can be done safely, but there's incredible fear and reluctance and a sense of being overwhelmed with the messaging. So as you'll hear, this roadmap emphasizes the obligation to be able to reassure patients and to then live up to that reassurance by providing very safe options. And then 5, and this is every day being highlighted, we had to finish the roadmap at a point in time. And then since that time, we've seen enormous surges in different communities. So we really have to be prepared and encourage people to look at local policies and ordinances due to the fluctuating burden of disease, which will affect availability of screening options and follow-up, particularly colonoscopy. Next. So how did we react to this? Caleb mentioned this. Just to reiterate, we, with the leadership of the Colorectal Cancer Alliance, CCA and the Roundtable hosted an expert panel, particularly regarding stool-based testing methods, although we looked at all the testing methods on May 5th. And then we published our CRC screening and COVID-19 playbook on June 30th. And here we are today with our webinar with the playbook lead authors, and we're going to share our main set of recommendations to you. Next. So here is the playbook, and what we really want to emphasize here, we're going to walk through each of these, so you don't need to write down all the numbers and you'll be able to get the playbook. But much of the guidance that had been coming out prior to this was guidance specifically for endoscopy suites from the GI community, or some guidance to primary care practices. The purpose of the playbook is to do what the roundtable members do so well, and to attack the problem from every perspective. How to public message, how to work with primary care practices, what kind of systems need to be in place, and really to engage all of our members in the kind of messaging and changes that are needed to get back to screening. So we think it's, I suppose we're biased, but we really do think it has a unique value compared to some of the other very important tools, all of which we referenced. But this really does have some unique value. And with that, we're going to launch into the specifics of our playbook, Recovery Through Alignment. And I believe Rachel is up first.
Thank you, Rich. As Rich alluded to, when it comes to colon cancer screening, there have been persistent disparities in screening that we've observed and have led to mortality differences. So specifically, African Americans and African American men have the highest likelihood of dying from colorectal cancer, are less likely to be screened. Same is true for Hispanic populations and Native American populations as well. But we really believe that this guide was important to state, for that reason, that despite the challenges we faced during the pandemic, that colorectal cancer remains a public health priority, and we have to provide the public with safe opportunities to detect colorectal polyps and to prevent cancer. As we know, due to the effects of the pandemic, there are overall fewer primary care visits and also fewer gastroenterology clinic visits. And as Rich has alluded to, endoscopy capacity has been severely limited by regulations that were initially meant to really help maintain supplies of protective equipment and to minimize individual patient risk. But as this pandemic persists, and as we are aware of the effects of colon cancer, the importance of still highlighting that message of the importance of screening. Colorectal cancer is positioned as a unique cancer because there are multiple screening test options. And therefore, as a community of individuals who are championing prevention of colon cancer, this is an opportunity to really utilize all of the tools that are available to us. You'll hear from others on this group today, but from our perspective, this really then means a multi-pronged approach can help us. And that's in part increased utilization of stool-based tests, That's reassuring those patients who are not of average risk that it is safe for them to get their colonoscopy. It's keeping track of patients who are missing or delaying procedures because of the COVID epidemic, and really using all of the resources that we have available to us during this time to ensure that the overall screening rates don't decline too substantially and that we don't widen the disparities that are already persistent in the communities I've highlighted. Caleb, next, please. So myself and doctors May, Balzora, Ajwanane, and Gray published this article that has been featured in Gastrointestinal Endoscopy. And this was written by us right when the COVID pandemic began, because we saw the impact that COVID-19 was having on populations, minority populations, and we could see the writing on the wall that these populations would again be further exacerbated by decreased screening. So unfortunately, because of COVID-19, there have been all of these shifts and pauses related to medical care, allocation in workforce deployment, and this really threatens to undo decades worth of work that's been employed to improve colorectal cancer screening and mortality disparities. Federally qualified health centers and community health centers have been even more harder hit. And so what does this mean for minorities and medically underserved populations? This means that screening participation has reduced. There are challenges now with follow-up of abnormal stool-based tests because partners that may complete colonoscopy, those centers are not at full capacity. There has been reduced community-based research because we're again encouraging individuals to stay at home, and many states have had and are now resuming stay-at-home orders. And there's also impacts on community engagement. So COVID unfortunately hit right at the beginning of March, which March is Colorectal Cancer Awareness Month. So a lot of activities that were planned to raise awareness and screening participation amongst communities that are most impacted, those events were not able to occur. So these are ways in which these communities have been really impacted. So what can we do as a community? And here I highlight 6 key points. So we can confidently reassure patients about the safety and importance of colorectal cancer screening. It's important to do this in the context of recognizing that these same individuals are at increased risk of COVID-19. But by reassuring them that our healthcare centers are doing the best that they can to protect them, and again, understanding that we are using this multi-pronged approach, which may mean for some individuals who are of average risk, we recommend a stool-based test up front with the follow-up colonoscopy later. But our messaging here is really important. Again, as much as we can to minimize patient contact with healthcare systems, by instance, using mailed fit outreach or mailing tests, other stool-based tests, I think will really be a key tool that we can use here. It's important that we identify GI, primary care, and community partners who are dedicated and want to help us in this effort. And so I'm very pleased to see so many on the webinar today and others who might join later. And I think COVID really highlighted the importance of extending our colorectal cancer screening efforts year-round. We no longer have March, so we now need to continue that message throughout the rest of the year. And we need to seek timely and innovative opportunities to serve medically underserved populations. So for instance, Fight CRC had money that had been set aside to engage in colon cancer screening activities. And once COVID-19 really hit those communities hard, they were able to shift that money into grant opportunities for those communities. And I think as an organization, you're going to hear from Michael about what CCA is doing. And we all need to think about how we can be innovative during this time to serve medically underserved populations. And Ma is going to walk you through the next aligning statement.
All right. Thank you, Rachel. So I'm responsible for alignment statement number 2. So as a broad statement, colonoscopy remains a safe procedure. It's a good option for screening and is quickly reopening around the country. But identifying patients who should receive higher priority for colonoscopic screening is a critical step. Of course, as what Rich was saying, this is a dynamic setting and a dynamic pandemic. And so even though when we were writing this, everything was really looking like, from a national standpoint, getting better, things have also gotten worse in the intervening time period. It's important to I want to share some perspective from the endoscopy side of things. In general, to maximize the safety of staff and patients, there are certain key principles that the endoscopy unit, as well as hospitals in general, are employing to reduce viral transmission. And these are informed by the GI societies, the Joint Commission, CDC, OSHA. And these key principles include, one, related to elimination, so minimizing visitors. So people who are coming to endoscopy will experience that. Administrative controls, including questions that are given to patients before they come into the physical premises, temperature checks, source controls such as universal masking, physical distancing, the PPE, hand hygiene, surface disinfection. So from the endoscopy standpoint, these are things that are now part of common practice that should allay fears that may be present amongst patients. And broadly, the safety of staff will result in the safety of patients. And so if we understand that these practices are in place, hopefully we can communicate these practices to alleviate those fears and anxiety that patients may still harbor. And in addition to that, just to also add that COVID PCR testing is a common practice now. In our setting, we do 1 week before the procedure, patients are COVID tested. And while it does not eliminate the risk of a COVID infection, it does reduce that. And it still applies that these key principles in terms of the way the endoscopy unit is practiced will reduce transmission. And so the overall summary, with that in mind, because of the current pandemic, potential closures, reduced capacity, prioritization of the patient population will likely continue to be an essential part of practice. Endoscopy units must be committed to a plan to address and allay patient fears. And then the clinical and non-clinical colorectal cancer screening stakeholders need to communicate within their communities about hindrances or access limitations in the health systems. And lastly, the local policies may not only vary based off the COVID pandemic, but it may change because of all of these issues that go up and down. Next slide. And so as a deep dive, when we talk about prioritization of the patient population, first thing that we want to say is that anyone who has symptoms, they should certainly feel comfortable coming into the endoscopy unit with all of these instituted practices in place to minimize the risk for those patients, because those patients are at highest risk. And so if you're symptomatic in any way, they should certainly come in. Now, beyond that, for those who are at highest risk for having a finding of, let's say, a neoplasm at the time of the colonoscopy, these individuals should be prioritized in terms of access for endoscopy, especially if there is a long wait time. These higher priority patients include those who have an abnormal stool-based cancer screening test, those with a family history of adenomas or cancer, those with inflammatory bowel disease, and those with genetic syndromes. And then the people who are at average risk for colorectal cancer and those who are undergoing routine surveillance colonoscopies, when there is a limitation in terms of the capacity for colonoscopies, these individuals can be assigned a lower risk. And then other screening options can be promoted. Next slide. So in terms of activating the CRC fighting community, we should be confidently reassuring our patients about the safety of visiting a healthcare facility to receive healthcare of any kind, and the safety of a colonoscopy during this era. We want to strengthen the community partnership between primary care and gastroenterology. And primary care providers will need to be aware of the level of burden, if any, that's experienced by the endoscopy facilities. And then the community organizations and coalitions will need to understand the communication priorities from local health systems and facilities to better disseminate the messages that promote colorectal cancer screening options. Next slide. Steve, to you, you can unmute yourself.
Thank you so much, Ma. So I'll address the aligning statement number 3. Before doing that, let me just mention 2 disclosures of mine. I received some consulting fees and research support from Exact Sciences and research support from the Colorectal Cancer Alliance. So the aligning statement 3 says, during a time when availability of elective screening colonoscopy may be limited by the COVID-19 pandemic, colorectal cancer screening can be safely offered through at-home stool-based tests. And as we all know, there are several safe and effective tests that have been endorsed by guidelines to screen for colorectal cancer. These tests are convenient for patients, especially in areas of high COVID prevalence, and the vast majority of insurances cover these tests. They can reach those in hard-to-reach areas, such as rural areas, or even hard-to-reach places in urban settings. And we're also aware that these tests can be mailed to patients. Importantly, a positive or abnormal test must be referred promptly for colonoscopy because a delay of 6 months or longer has been associated with higher rates of advanced adenomas and late-stage colorectal cancers, at least for FIT testing, and we believe the same thing would be true for multi-target stool DNA testing as well. Next slide, please. So most of the people on this call are probably familiar with the stool-based test, but just in case, the 2 that are most commonly discussed are FIT testing and multi-target stool DNA testing. Fecal occult blood testing is still used in many settings, and if you're going to do guaiac-based testing, it should be a high sensitivity guaiac test. Next slide. So in terms of the deep dive topic, it's important to think of stool-based testing not as the test, but as a program. It should be viewed programmatically, and you really should have systems in place for ordering and distributing the test, making sure that it gets done, obtaining the results, and acting on a positive and negative result. Now, both FIT and multi-target stool DNA tests must be ordered by a clinician, most commonly the patient's primary care clinicians, although they can be ordered through urgent care centers, retail clinics, or independent telehealth providers. Now, if a positive stool test happens, then patients, as I said, really need to be referred promptly for colonoscopy within a few months, ideally, but really not longer than 6 months. This will require close communication between primary care practices and GI practices. And remember that if a patient does a positive stool test and the colonoscopy is not performed, that's really not a completed screening round. Most people will have a negative stool-based test. The vast majority of them will. So then you have to have a program in place to follow up people after a negative test. So in the case of FIT or guaiac testing, that should be annually. In the case of multi-target stool DNA testing, it's recommended that there be a 3-year interval. Next slide. So I took this slide from David Lieberman, which really highlights why one needs to think of things programmatically. So, for example, if you offer a FIT test, next slide, you really should know whether it's been completed. And what I've highlighted here in red are metrics, quality metrics that really should be followed when one is doing a FIT program. So if a FIT is completed and it's positive, what is your completion rate for getting colonoscopy performed? If the FIT is completed and it's negative, then you should be ordering and offering annual FIT testing and track how often are the annual FIT tests being completed. So again, thinking programmatically about what happens after a positive test and a negative test. And there was a very good paper that just came out. Samir Gupta is the first author with Gloria Coronado, a real nice review on mailed FIT testing. And if you click on this link in the slides, it'll take you to that paper which just came out. Next slide. So activating the CRC fighting community, you really need to be discussing with your patients and frankly with the entire community that stool tests are important and the very effective options for colon cancer screening. They're safe even in areas of high COVID prevalence. There's little or virtually no evidence that COVID is transmitted by stool. You can find COVID RNA in the stool, but live virus to my knowledge and those experts that I've spoken to, live virus hasn't really been cultured from the stool. So we should try to reassure our patients about that. You need to understand how DIAGNOSES testing, FIT testing, and multi-target stool DNA testing are being conducted in your environment, and which of these tests really should be offered, and make sure you have tracking and reminder systems. And then importantly, make sure that you have close communication between the primary care and colonoscopy practices.
Great. Thank you, Steve. I'm going to be touching on the aligning statement number 4. Thank you, Dorado. I know he's unable to be on the call today, but he helped author this piece here. The alignment statement number 4, gaining momentum and reigniting screening activities and public messaging will be highly dependent upon local regulatory requirements, public health priorities, and policy change. So if we look at the 4 pieces that go into that, obviously enhanced patient protections, while obviously necessary, we think will create added barriers for already apprehensive unscreened populations, causing potentially further delay. Some practice changes implemented in response to the pandemic will likely remain a permanent element of our healthcare environment. So televisits and telehealth visits, finding ways to provide continued access to care for the millions of individuals who have lost their jobs and associated healthcare is an important area of focus, as Rich said, and additional policy efforts around eliminating the financial barriers is incredibly important. Next slide. So taking a little deeper dive into the actual public messaging piece, a first requirement in reigniting screening activities across the US is realizing that simply reopening facilities and offering screening will not be enough. You'll hear a little bit more about this in a moment. Some of the new safety measures may exacerbate patient fears and create the impression that these environments are crawling with COVID-19, which we all know is not true. Providers and facilities will need to find compelling messages, and I would add patient advocacy organizations and others as well, to remind patients that these measures are designed to protect everyone and are not in place because of any identified risk in the facility. Next slide. So I know this slide is a little bit complicated, added a lot of information here. The Colorectal Cancer Alliance, along with NCCRT and other partners, are moving forward with some of the recommendations that have been outlined here. As you can see on the left, we are putting forth and will be launching, hopefully in the beginning of September, a public awareness campaign that will be directed at the general public and primary care. To the right, this is not the actual creative and or the final messaging, but here's an idea or thought of what that could actually look like. So kind of going on the COVID-19 theme, things are different, but your colorectal cancer risk is not. So looking at, and I won't go into all the details in this piece here, but the primary message is colorectal cancer didn't stop because COVID-19 started. Screening can't wait. Know your options and get screened now. And then the second piece of the Alliance's kind of program is this personalized navigation website. So this public awareness campaign, again, would drive to this website and provide information on screening, including location, type of screening, availability, and full navigation for positive stool-based tests. On the right-hand side is a rather complicated slide, but it starts with a patient or a family member will actually go to the slide. There'll be an adaptive questionnaire, a risk stratification tool that will assess the patient's risk from low to high. From there, there'll actually be a recommendation on what that potential screening option could be, along with the next slide. The next piece there is the education around the shared decision-making tool. Let's say they are at high risk, they would go directly to a GI finder with one of our partners and potentially be able to make an appointment right then or there. If they may be at average risk and it sees viability of a FIT or a stool DNA test, it will actually work on the back end to help get those scheduled either with their primary care physician or a GI doc. And it will help actually then navigate them to a colonoscopy if they have a positive test. So if anybody is interested in this program, we'd love to partner with you on it. Next slide. So just closing out here, an activation, so confidently reassuring patients about the safety. I think that's incredibly important. You know, organizations like ourselves, Fight Colorectal Cancer, and others, I think we've been really concentrating on this because, you know, I'm hearing from patients all over the country that they're really concerned about this drop in screening, not just for themselves, but obviously for patients and their families as well. Rachel, I think, mentioned this earlier in terms of extending CRC awareness events to year round. I think we're going to have to get really, really creative in this world, whereas before there was health fairs, there was all sorts of activities happening on the state and local level in person, and how are we going to do that in a virtual world? The implementation of screening via telehealth obviously requires new approaches, best practices, and lessons learned. And then the last couple are due to the consequences of the pandemic, including a potentially greater adoption of stool-based testing, as well as a growing number of newly unemployed and uninsured individuals. It is imperative to address unfair payment policy and CRC screening. I think this has been mentioned multiple times, the uninsured or the additional uninsured. And then again, shifting advocacy events and policy campaigns to virtual platforms whenever possible.
All right, excellent. Thank you so much all, first off, for such informative session for us. And then also, I just got to say, congratulations, sticking to time. You nailed it, speakers. Rich, as I transition, I'm going to transition some of the slides here and start to dive into some questions, but do you have any summary thoughts that you'd like to just close with? Sorry, you're on mute. I'm going to unmute you here.
I wanted to be that guy, you know, who was muted when he was started. Working with this particular group of people has just been a delight. We really worked on this project with a sense of urgency, a very, very rapid timeline. And that sense of urgency, I can assure all of you, is not going anywhere. So everybody who you've met today is kind of in this for the long run. And you can feel quite free to reach out through the NCCRT, and I'm quite sure I speak for everybody on the panel to say directly to people on the panel to kind of pick their brain more and get some ideas. The second point I'd say is partnerships. I've already heard from some areas, places, FQHCs who are doing some very innovative work. So I think one thought that occurs to me is that as people come up with local solutions to some of these barriers, that maybe the NCCRT could just have a resource on the website where we just, encourage people to say, hey, I heard about this idea, and just let people go in and see the ideas so that they can pick the ones that work for them. The third is this fascinating and very challenging balance between the message around how safe the options are, how all the options can be used and are very, very important. But at the same time, watch your local pattern. And those can be very, so we say it's very safe, but then you look at your local patterns and it doesn't look so safe. So I'm really going to kind of push the panelists to comment on that a little bit. And then the fifth issue, and then I'm going to turn it over. Maybe, I'm not sure which one of you wants to go first. Maybe Steve can go first on this question that I saw in the chat, and I know others have, is really to understand more deeply the role of testing before colonoscopy. And I know different locales are doing it differently. And I'm very concerned about the speed of results. I think all the big issues are here. I think the general outline is here. And I think what we need to do now is start digging ever more deeply into the specifics.
Yeah, and I'll kind of help moderate some of these questions here. And I think, Steve, Ma, Rachel, probably all could chime in on this. But the question was, there was a call this morning, I guess, that one of our attendees had, and that they had varying time limits between when they would get a COVID test and whenever they would go in for the procedure. So 72 hours, 48 hours, and some no testing requirement at all. Again, as we, I think, said throughout the presentation, those are going to be varying by locality, but I guess just some general thoughts to cover that session.
Steve, why don't you kick it off, because New York was a little bit ahead in this.
Right. Well, here at Mount Sinai, we have a 48-hour rule where our patients are getting COVID tested about 48 hours or maybe 72 hours before. But we feel that 5 or 7 days between a COVID test and the procedure may be too long, because people might theoretically get exposed to COVID during that time frame. I'm not aware of a unified opinion on this, but clearly, the shorter the interval from the COVID test to the procedure, the better. The problem is a lot of COVID tests take a while to come back. We're fortunate that our lab will give us a result in 6 to 12 hours or no more than 24 hours. But there's many labs that have a 3 to 5, sometimes 7-day turnaround. So it depends, I think, on what testing lab is being used. But ideally, you want it to be as short as possible before the procedure. Any thoughts from Ma or Rachel?
Yeah, I'd be happy to chime in a bit, but I think that those key principles are present all across the country. Within our system, I think that there is some concern around the turnaround time. Our turnaround time to date has been fairly good, which is 1 to 2 days, but it's not rapid as, it's not consistently 1 day. So I think instituting, let's say, within 48 hours, sometimes logistically is just very challenging. The way we've done it is 1 week. And I know that there's that window where someone might be exposed and turns positive. And then I think in those settings, the other practices and principles that we discuss kind of come into play, which is, you're reducing individuals that are symptomatic that come into the physical space. You're trying to ask those questions as well as the temperature checks. And then when you're there, you're masked and covered. And then the staff are also masked and covered. And so there's minimal, hopefully, opportunity for transmission if there's an asymptomatic individual that is in the system. And then physicians at that point has the opportunity to decide whether or not they want to choose a rapid test, which usually has a turnaround time of, within as early as 45 minutes, but sometimes 2 hours. Those tests they tend to be limited. And so I think in our system, our providers are asked to be judicious about who needs it. For colonoscopies, typically we don't, just because the risk of transmission during a colonoscopy is perceived to be low, as opposed to an upper endoscopy where someone is being, induced potentially to regurgitate or cough or vomit. And then when I saw this question during our talk, so I just sent some quick emails to our infectious disease specialist as well as chief medical officer. And they were saying that they're having a discussion even today about this issue, because the CDC provided some guidance last week around moving away from PCR-based testing, but more towards clearing patients based off of time and symptom-based guidelines. So I don't know how that's going to play out going forward, but it's been a dynamic process, during these last couple of months.
So I'm going to move us on to another question here, and I'm going to try to combine a few of them to the best of my ability here. So panelists, stick with me. There's a general question on, I think, the role that key stakeholders can play as we're getting people back to screening. And one specific question was kind of on what initiatives are in the works for targeting primary care providers and discussing colorectal cancer screening and triaging that eligible patient. But there's also some questions about, are there any creative or any innovations or any interventions that people are considering about partnering with pharmacy and immunizations, partnering with other stakeholders, industry stakeholders. So how do we, and I think generally a kind of a theme of questions here is how do we include them in the process? And is there any conversations and work about how to include them into these processes of reigniting screening?
I think of the one primary care doc on the panel, I'll take that one. I've seen a great deal of interest kind of locally, practice to practice, center to center, because these primary care practices are accountable for their quality numbers, and it's been built into their sense of obligation. And I've seen a lot of the innovation coming from them. What I don't know the answer to is whether some of the larger, particularly national organizations, have prioritized this, as opposed to, I think, a little greater priority going towards big practice questions. Is your practice financially solvent? Is your practice going to be able to continue to exist? Particularly for the smaller non-owned practices, which I think I've seen a little bit more attention paid to that. So I think that's something that the NCCRT could take on, is to reach out to some of the parent organizations. I think a lot of the real work that is good work, it's been some of this local work.
And I will say before I think Rachel is going to respond to, for the primary care aspect of it, we did include a letter, a sample letter with our piece. So whenever you go to the website, nccrt.org, and you go to our resource center and find this resource, you'll also see a letter that you can model some templates after of how primary care can be involved in this too. So Rachel, please.
So I sit in part at the Fred Hutchinson Cancer Research Center, which has the grant overseeing all of the COVID vaccine trials happening across the United States. And so I do know that one of the conversations that has come up is how can we incorporate pharmacies into not only the COVID vaccine once it's available, but also screening, cancer screening, and specifically around colorectal cancer screening and HPV screening, which has also really plummeted during this COVID-19 era. The questions that have and issues that have come up around that is, how do you then address payment models that are currently in existence that don't really support those types of partnerships? But just as we've seen innovation being driven by the use of telehealth during this time, there's a lot of interest in understanding how different payment models could be structured to address that, as to prevent other public health crises. And large payer systems and health insurance planners are part of those conversations. And so I think that that is something that we will see more of moving forward into the future.
Another one that I wanted to jump into talks a little bit more for maybe some of the attendees that we have on the call about, and this kind of speaks to Dr. Winter's slides about the trends that we're seeing and the foreseeable trends. Within your health systems, within the National Colorectal Cancer Screening Campaign, within CDC programs, do we see there being some adjustments to programs and maybe some of the goals that we're setting and some of the activities that we're trying to put into place?
Yeah, I think we have not had any discussion about, about the goal of 80% in every community at the roundtable level. One of the things that I've commented to quite a number of my colleagues, that if you look at some of the enduring successes of the 80% in 2018 campaign, really quite remarkable, is that when we launched that campaign, the healthy people goals were under 80%. And people used to look at 70% as a good goal. And I think we could all universally say nobody talks about 70% colorectal cancer screening rates as an acceptable goal anymore. I mean, absolutely, that's out. Everybody has embraced 80. So I think we have to accept, which is going to be tough, we're going to take a step back. We're going to take a step back. We could go beyond, even before we launched 80 by 18, but we will recover more quickly because people have prioritized this and put the systems in place. So we haven't seen any change in goals. I do think that we all understand that if you're not tailoring everything you're doing to the reality of COVID, that you're not living in the world that everybody else is living in and that the health systems are living in. So I think everything we have to do, that we communicate, has to have that filter.
Okay. Just pausing to see if the panelists have any other thoughts on that one. If not, I can move on to the next one. I'm going to combine a couple of other questions too, because I think this is a really important point. thinking about, as we're delivering our colorectal cancer screening messaging, are there ways to partner with other cancer screening messaging, public messaging that's going out there, or other public health diseases that are going out there? Can we be more comprehensive? I think we addressed this in our slides where we talk about the patient populations are going to be overwhelmed with a lot of public health messaging coming at them, not just COVID messaging, but also other disease states. And also the health systems and the health centers themselves are reshifting their priorities and may need to find some avenues where they can kind of combine some of those priorities. So thoughts from the panel on that? Maybe Steve, I don't know if you want to chime in.
Yeah, on the roundtable, we had these discussions a lot, even in the pre-COVID era, about, combining cancer screenings, breast, cervical. And obviously, I think in your location, everyone has to decide what is feasible in terms of messaging. For example, are you still as set up as you were for pap smears and mammograms and the outreach in that regard? Presumably the answer is yes. And I feel that it's probably worthwhile to broaden the message to all cancer screening. But because of the complexity of colorectal cancer testing and screening, sometimes when that's combined with other messages, it gets lost or not as well appreciated. So I think it depends on, my approach would be dependent upon your locale and also the prevalence of COVID in your locale to decide whether you want to combine message or not. But I think any messaging is important these days.
The only thing I'd add to that, Caleb, is I think the general messaging of the value of cancer screening is a good one. I think execution is very difficult to do in a big group because people are overdue, out of date, different risks. You have to get down to the level of the individual awfully quickly. And it does demand some degree of individualized approaches. I can tell you that a lot of primary care practices or systems that do population management do communicate with their patients. Here are all the things you're due for, and here's how you're going to get it done. So I think that's great and very appropriate. Ultimately, though, it's perfectly fine to me that if you have a group who's enthusiastic about getting people up to date with colorectal cancer screening, let's do it.
Michael, lots of questions about your slide and what the Colorectal Cancer Alliance is doing. I've seen you've been able to answer those in text a little bit. And obviously, if folks have interest in partnering with that navigation system or other public messaging, reaching out to Colorectal Cancer Alliance, I think will be welcome and appreciated. But I see you've been monitoring. You want to answer any of those particular questions?
Yeah, no, I mean, I think the questions about the patient navigation tool, I think this is a long-term project for the Alliance and not just for screening during COVID. And so, looking at the future, love to talk to any folks about, the systems approach, any back-end technology, how we can integrate with, anything and anyone that are, doing fit navigation, GI folks, et cetera. And then one other thing I would just touch on, Ari, the public messaging. We have had a couple conversations with Quest and LabCorp. And actually LabCorp is putting together a kind of all across the board, kind of get back to your health message. So if folks are interested in that on a local level, I don't know, Caleb, if maybe they can reach out to you to get connected to LabCorp, but they are doing kind of a broad-based approach as well.
Yeah, and another thing I'll mention about what's kind of a nice example of Colorectal Cancer Alliance, a nice example of what some of Fight CRC is doing and what some of the American Cancer Society is doing, is being able to take some of what's in the playbook, take some of these conversations that are going on and forwarding them and trying to, work together and build consensus around these issues. I think it's been a good conversation from the colorectal cancer community so far to be doing that. Obviously, this report is a good example of that, but it's going to be so much more needed going forward. Rachel, I know that you and Dr. Gray, you were able to kind of talk about your particular disparities piece, but I do think maybe ending the call on just some some final considerations towards, as we're doing this work, making sure that we're continuing to accelerate our work addressing cancer screening disparities, health inequities, and in general public health inequities.
Yeah, so as I touched upon, as most on this call know, COVID-19 is disproportionately impacting, and unfortunately, people who are Black, Hispanic, Native Americans are more likely to die from COVID-19. So there's real concern amongst those populations of contracting COVID-19. And as we've all expressed, it's really important that we state how centers are making sure that those patients are safe from COVID-19. So part of the testing that's happening prior to the endoscopy, the PPE that providers are wearing, the distancing that endoscopy suites are creating, all of those things are really to ensure that our patients are safe from COVID-19, in addition to the things that they're doing themselves at home, like hand washing, mask wearing, and social distancing. And so by doing this, in addition to making sure they're protected from COVID-19, we're also trying to reduce their risk from colorectal cancer, which again, unfortunately, those populations are at high risk for. So I think that messaging is really important, especially for underrepresented minority groups, is acknowledging their risk, reassuring them about safety, trying to encourage them to continue to do the things that they're doing, but at the same time to prioritize colorectal cancer screening as much as they can. Ultimately, I think we all want to, when COVID-19 is under better control, hopefully not have new crises, new public health crises from preventable diseases like colon cancer to have to confront.
And I might actually just ask one more and finish kind of on a policy note, and something that's just going to be a very tough barrier for us. There's been a lot of questions, comments about costs, about uninsured, underinsured, and even the programs that are meant for those folks being placed on hold because of budgets. I guess it's asking if how we're handling this. I don't know if we have some general advice that we can kind of give now on those particular issues, but I think it's probably worth addressing some of the really big barriers that we're going to be coming up with against unemployment rates, those being uninsured, and the programs helping those folks being underfunded or not funded or on hold.
I'll just quickly comment. I think hits on probably the single most difficult issue that our entire country is coping with. The healthiest way for practices to deal, and health systems to deal with their own economic challenges, is to get the COVID crisis under control as quickly as possible in their communities, so that the more that everybody in public health can engage every possible group to support messaging about leaving a physical distance, wearing masks, washing hands, and doing the right things for others, the better. Because if you look in the Northeast, the volumes of care are getting very quickly back towards normal, which then allows everybody in the health space to feel economically more secure. I think the areas that are dealing with these surges and are needing to back off, it just has a tremendous ripple effect economically. So it's a terribly difficult message. But just to say, that is one area I think where all of us in health can work together to emphasize that everything benefits the more rapidly we can suppress surges.
Excellent. Well, that puts us at the end of our session, and I want to thank all the panelists and everybody for joining us. As a reminder, we will be sharing the slides. I'm sorry we didn't get to all questions on the call. We will be sharing those questions with our panelists and try to get you back responses. They've been able to answer some of them through, so we'll try to record as many of these questions as possible and get those back out whenever we post this webinar to our website as well. So with that said, you'll be getting an email with slides either probably by tomorrow whenever we get the attendee list back for this event. You'll get an evaluation in that, and we hope you please do fill that out so we can keep providing some great webinars for you all. Appreciate your time, and thanks again to our panelists, and we'll talk to you next time.
Thanks, everyone.